Hello and welcome to this video on the renal system. The renal system effectively covers your kidneys, ureter, urethra and bladder. In short, everything involved with pee. The important thing about the urinary system is that arguably urine is the waste product of it. That is the waste product of performing its intended task. The intended task being fluid management. Although more specifically, it's blood volume management through fluid management. This is achieved through the control of electrolytes, the effect of osmosis and separation of blood from plasma and then later filtrate. To understand what the urinary system does and does not do, let's follow the process of urination from start to the rather unfortunate end. In terms of the functional unit or substance of the human body, we're going to talk about the kidney, and there are two structures we need to talk about. We have the cortex, which is the outer part of the kidney, and we have the medulla, which is the inner part of the kidney. Now, in terms of looking at this, you can think of the cortex as just being the outer strip. If you were to look at this with a cross-section of kidney, you can see that you have these lighter parts and these darker parts. The lighter part is the cortex and the darker parts are the medulla, although specifically speaking, the darker parts are actually the renal pyramids and the areas in between are also part of the medulla as well. So it's only this periphery area here. There are between 8 and 18 cone-shaped areas, and each of these are called a renal lobe. And these are what we are referring to as the renal pyramids. In between each of these, within the medulla, is an area called renal columns. These are part of the renal cortex that pokes through them and holds everything in place. The tip of each of these pyramids joins into the minor calyx, and the minor calyx enters into the major calyx, and then the major calyx enters into the renal pelvis. The renal pelvis eventually becomes the ureter, and the ureter eventually finds its way to the bladder. Importantly, within the kidney itself, you have both blood supply and nervous supply. That is, you have nerves going into it, which both detect signals and send signals back to the brain and other parts of the body, and you have a blood supply that takes in blood and takes away blood that has either not been used or that has been cleaned by the kidneys. In terms of the nervous supply for the kidney, in terms of the renal system, we are pretty much talking about just the parasympathetic and sympathetic nervous system, and that's because the kidneys are there to respond to blood volume. Your parasympathetic nervous system is what works when your blood volume is how and where it should be. Your sympathetic nervous system is what kicks in when your blood volume starts to, for the most part, become too low. Now, to be very clear about it, the parasympathetic nervous system does arguably respond when blood pressure is too high, and it does this by reducing blood volume through removing fluid volume in the form of water. It's the sympathetic response, which is the body's attempt to increase blood pressure if it perceives it to be too low, that is where things often get interesting. But for now, we're not going to talk too much about that, as it's largely something initiated and controlled through hormones and nervous stimulus. So we'll get to that eventually, but for now, just understand, parasympathetic system is the normal state of the body, and if blood pressure is too high, is sympathetic if blood pressure is too low. Let's begin with the arterial system, specifically the renal artery. There are two of these, with one going into each kidney. Blood enters into the kidney at the renal pelvis, or the center of the kidney. From here, the artery splits into smaller arterioles, and these eventually get to the renal cortex, this being the outer part of the kidney we mentioned earlier. Importantly, the amount of blood filtered and arguably entering your kidneys each day is measured in hundreds of liters. In fact, it's about 200 liters of blood each day. It means your kidney is going to be filtering roughly 120 or so milliliters of blood every minute. When we talk about the renal cortex and the arterioles, we need to look at what they're interacting with, and this is the functional unit of the kidney. It is called a nephron. The blood that enters into the nephron is not actually blood in the truest sense of the word. Instead, blood entering into the artery flows into a structure called the glomerulus. This is the start of the nephron, and it's the first stage of filtering blood and blood components. The glomerulus acts as a sort of membrane or filter. The membrane keeps large things in the blood. Specifically here we're talking about cells and similar, while it allows small things to enter into the nephron. The glomerulus functions through several things, one of which is the pressure. This is why if you have hypertension or kidney disease, you can find that your urine has content in it that shouldn't be there. For example, blood in urine, proteins, and similar. It's because the damage to the kidney allows for the pressure to exceed its ability to stop content from being forced through. The process is called glomerular hydrostatic pressure, and it's the primary force responsible for effectively forcing content through the glomerulus. Now, the pressure is not so high that big things can get through, but it's just high enough that small things can get through. We're talking here about water and solutes. It's generally going to be well below 55 millimeters mercury, remembering that blood pressure is measured in millimeters mercury as well. If, under normal circumstances, you were to measure the glomerulus, you would find that the amount of pressure within it should be relatively low. And to be clear about this, it should be somewhere around 10 millimeters mercury. This is because you have a range of forces and pressures that are pushing and pulling in different ways. Because of this, you have the arterial pressure, you have the colloidal pressure, that is the force of the protein cells and similar in the blood pulling on the water within it. You have the osmolarity of the water itself, that is the dissolved solutes. And there are a few other things as well. Overall, the reason you need a arterial feeding this and not a capillary like other parts of the body is that you need that higher pressure. By comparison to a capillary, which is normally about 0.3 millimeters mercury, to be blunt about it, 10 to 15 millimeters mercury of the arterial feeding the renal system is significantly higher. Why you need that pressure, other than the fact that it does force this content through, is that you have multiple layers of filtration within the glomerulus. The first is the fenestrated endothelium. What this does is it prevents large blood components, like cells for instance, from being able to get through. This means you're not going to be peeing out blood all the time, which would rather obviously be bad for your health and well-being. This first layer of separation is almost entirely based on the premise of size. The next is the basement membrane. The basement membrane has a physical barrier to it, a physical barrier that specifically works on negative charge. This is what's going to prevent proteins from passing through, as most proteins have a net negative charge. And then finally, we have the foot processes. These are done by the podocytes, and they effectively provide a more granular level of filtration. What does not pass through these different membranes of the glomerulus will exit the nephron and re-enter the blood circulation via the afferent arterioles, and eventually into the renal vein. This leaves a surprising amount of blood content in the nephron. Still, but it is only at the start of the nephron, somewhere between the glomerulus and the Bowman's capsule. Outside of the glomerulus, you will find the Bowman's capsule. This is to a certain extent another layer of filtration. Well, more accurately, it should be said that it is a layer of absorption, as it absorbs the filtrate from the glomerulus to better allow the human body and renal system to filter the contents of the filtrate. This leaves small molecules, things like amino acids, electrolytes, metabolites, and more in the filtrate. A typical filtrate fraction will be between 16 and 20% of the blood that enters it. Now, to be clear about this, the amount of filtrate entering into the nephron is by no means what will be expressed out of the body as urine, and you'll understand why that is shortly. Before going any further, we do need to talk about what will, to a certain extent, dictate the amount of filtration going on, or more accurately, how the body knows that it needs to remove fluid volume in particular. The human body does not sit there and constantly produce the same amount of urine at all times, and that's because of several factors, one of which is simply that, you don't always need to get rid of fluid in the body. There is a base level of urine production, and this is the minimum the body will make in order to be able to produce urine and remove waste material. It can, to a certain extent, increase this, or alternatively, it can try and dampen it, although that's not so easy to do. The way the body does this is via something called baroreceptors. You'll find these in the aorta and the carotid sinuses. When blood pressure goes up, these baroreceptors get activated, and this tells the human body that there's too much fluid, and more accurately, there's too much blood volume. Therefore, we need to get rid of it. One way to do this is initially to start with vasodilation, that is increasing the blood vessel size. The advantages of this are that, well, in terms of the renal system, the arterioles supplying the glomerulus increase in size. This increases the amount of blood entering the glomerulus, and therefore the glomerulus has more opportunity to filter out the content. This increases the amount of water that enters into the nephron and therefore becomes urine. If, on the other hand, blood pressure goes down, as ideally it should, if you have this sort of situation, the vasoconstrictive effect of the sympathetic system comes into effect, and this will result in lower glomerular filtration and blood supply to the kidneys. This means you have less water leaving the body. The decrease itself is detected by granular cells which are found in the efferent arteriole, and this is found just at the start of the kidney. When these are stimulated, they release an enzyme, and that enzyme is going to create or lead to the creation of renin. Renin is what tells the body that blood pressure is too high. Renin leads to aldosterone, aldosterone leads to angiotensin 1, leading to angiotensin 2, and this then results in changes to the blood volume within the body, particularly talking here about the modification of how much sodium is either retained or removed from the body, and therefore how much water volume is retained or removed from the body. Curiously, this is also one reason why during the menstrual cycle, females have a greater retention of water. The progesterone molecule, or specifically a hormone in this case, has similarities, structurally speaking, to the aldosterone molecule hormone, and these can both bind to the same receptor. When this happens, it leads to an increase in sodium in both cases, although because progesterone binds less well to the receptor, you get less retention of sodium. But when that does happen, that is, sodium is retained, you get increases in water volume, and this results in things like bloat. Another mechanism that can lead to changes in blood volume control is that of atrionatriuretic hormone, or peptide as it's also called. These are released by cardiomyocytes in the atria, and they are released when the atria is stretched more than usual. When this happens, it releases the atrionatriuretic peptide, and that inhibits sodium recovery or reabsorption in parts of the kidney, and we'll talk about that in specific detail and get to that part of the nephron. When you have less retention of sodium, you have more water being disposed of along with that sodium, as the water will follow it due to the effects of osmosis. And now that you know what's going to tell the human body when and how to filtrate things to a certain extent and tell it to remove more of the water, we can look at where that actually happens, and specifically the blood that has either been increased in its delivery to the glomerulus or decreased in the case of having too little water or blood volume is going to be absorbed by the Bowman's capsule once it's been filtrated. Once it's filtrated, it proceeds onto the proximal convoluted tubule, but that's just the first step. After the proximal convoluted tubule, it's going to enter the loop of Henle, and this is made up of 4 different parts: the thick descending tubule, the thin descending tubule, the thin ascending tubule, the thick ascending tubule. After these, it then enters the distal convoluted tubule. And yes, all these names are pretty much exactly the same, just differing on how thick they are and their location. Each part, but particularly the loop of Henle, do something slightly different to ensure that your body reabsorbs what it needs and discards what it does not need. To start with, we have the proximal convoluted tubule. This is made up of layers of endothelial cells which make up what is practically a hose. That hose allows for either material to be pushed out or reabsorbed. Arguably, you could say that it's absorbing the contents back into the bloodstream. And so depending on whether or not you're viewing this as a student trying to write for a university level assessment or out of curiosity, the difference may or may not be important. Under normal circumstances, and this is assuming an otherwise healthy adult, the proximal convoluted tubule will reabsorb just about everything that is in it. The first and arguably most important things it's going to look to reabsorb are going to be glucose, amino acids, and the vast majority of the water and salt content. And we say a vast majority as we're talking about 2/3 or so. The reabsorption of sodium to start with is done via active transportation. This is a sodium-potassium pump. What you do is you pump potassium into the inside of the proximal convoluted tubule and you transport sodium out, and it's a roughly 2 to 3 exchange. Because you are moving sodium, the water will then follow from this. The presence of things like glucose, amino acids, and vitamins and so on also assist in this, as they create a gradient that will, through the power of osmosis, draw the water out of the nephron and specifically the proximal convoluted tubule. To some extent, anything that's lipid soluble will also be reabsorbed at the same time. This can include things like urea. Along with reabsorbing the urea can also be absorbed into this part of the tubule as well. This is important as you want to be able to both absorb and dispose of those things you do not want within that part of the tubule. In terms of moving further down the tubule, we have the descending, otherwise known as the nephron loop. This has what is effectively 4 parts to it, although it's largely divided into the ascending and descending sides. Each of these has a thick and thin section, although for the most part, the functionality doesn't change between them. On the descending side, which is the first side, you largely reabsorb water from within the loop. This allows you to take away just the water itself. Towards the bottom of this, which is the thin section, you are absorbing urea into this once more. This is eventually going to form urine, which is why we're adding it again. Once you start traveling back up the ascending loop once more, you are reabsorbing the variety of solutes, primarily looking here at things like electrolytes. These will, by virtue of the way things work within the human body, and for that matter within just nature in general, travel down a concentration gradient. Because you have a vascular supply around the nephron, this is constantly going to draw away any material that you have reabsorbed into the body. This means that the area around the nephron always has a low concentration of solutes within it. It allows the reabsorbed material, particularly things like electrolytes, to be in a high concentration around the nephron, a low concentration in the bloodstream, and therefore travel into the bloodstream and get carried away. It is important for us to point out that in the ascending loop of Henle, there is no water reabsorbed. It is just the solutes in the form of electrolytes primarily, but other things as well, and these are all passed through via transporters. That is why there is no movement of water. After you have the ascending loop of Henle, we have the distal convoluted tubule, and this is largely there to focus again on various solutes, although rather than just electrolytes, we are looking at a variety of other material as well. There are things like bicarbonate. This is part of the bicarbonate buffer system. You also reabsorb things like calcium, which are regulated via hormones, so the body knows whether or not it should be reabsorbing more calcium, more of the bicarbonate, and so on. Following from the distal convoluted tubule, we have the collecting tubule, and this is effectively the final stage of reabsorption. And here we're again looking at things like electrolytes. You want to transport sodium as much as possible, and not just are you looking at trying to transport sodium, but you're trying to ensure that the transport of sodium, which is regulated via hormones like aldosterone, and calcium via parathyroid hormone and so on, are all in the right amounts. That is, if you are trying to increase reabsorption, and therefore increase blood pressure, you want to try and increase the amount of sodium you take back into the body. If you're trying to get rid of blood volume, you want to minimize the amount of this that you're reabsorbing. At least initially within the nephron, about 2/3, 66 to 67% of water, sodium and potassium that goes into the nephron is going to be reabsorbed. You also have just about everything else in terms of glucose, amino acids, and other things like vitamins and other similar substances are all recovered if you are healthy. Now, this is an important caveat. If you are healthy. If, for instance, you are diabetic, you may find that the body is unable to utilize all the glucose, and therefore glucose may show up in your urine. It's also possible, after a carbohydrate-rich meal, that glucose may appear in urine as well, and that's because the amount of glucose within your body, and as a consequence the amount passing through into your kidneys, exceeds the capacity of the proximal convoluted tubule to reabsorb it. This is called being saturated. If outside of those exceptionally high carbohydrate meals, you still have glucose showing up in your urine, it's an indicative sign of something like type 1 or type 2 diabetes. And that is because the amount of glucose circulating in your blood is unusual, leading to unusually high levels of glucose in your urine, simply because the nephron cannot accommodate the excessive amounts that are present. Now, to understand the primary role of this, the whole nephron exists largely to try and dispose of excess fluid, thereby either increasing or decreasing the blood volume through controlling fluid levels in the form of water. There are, however, certain exceptions to this, and this exception is in terms of what we would consider waste, specifically here thinking of metabolites and drugs. And this is where we need to talk about just how the body deals with it. In terms of the glomerulus, we've mentioned how that's intended to try and prevent things like proteins, cells, and similar from getting through. That is true. However, further in, when we talk about the loop of Henle or the nephron loop, you'll find that the body has the ability to effectively push these proteins and metabolites into the urine. This is done by using particular channels. And by doing so, you're able to put metabolites or waste products or drugs into urine. And this is how the body gets rid of them. It doesn't pass through at the start of the process, unless it's a small drug molecule. Instead, it's added later on. Now that we've finished with the renal system or the kidney itself, and we have urine, it now needs to go somewhere to be stored, and this is first done by taking it into the ureter. The ureter is effectively just a tube connecting your kidneys and your bladder. There are 2 ureters in the body, one on each side for each kidney. These are effectively just thin structures that are there solely to facilitate the movement of fluids. It's why they only have 3 layers. A mucosal layer in the center, and this is what's going to effectively allow for the movement of rather nasty waste products, for example, the hydrogen molecules in urine that make them acidic, without destroying them. An epithelial layer, which is there to provide a degree of structure, and then a second epithelial layer, which is also there to provide structure, just running in another direction. Around this, you'll find fibrous connective tissue, which is what's going to keep everything wrapped up nicely together and prevent it from falling apart. The muscle layers are necessary, partly just to provide peristaltic contraction, that is, to squish the urine down, rather than having to wait for it to build up and gravity to take effect. By having peristaltic action, you're able to force urine down and into the bladder without it sitting inside of the ureter. Once urine is in the bladder itself has a somewhat similar structure. It is in and of itself just like a giant balloon, except in this case it's a giant balloon with a variety of rubber bands wrapped around it. These rubber bands are wrapped in different directions, effectively 3 very similar layers to what's in the ureter, except that, well, the muscle layers are slightly differently lined up. There's also a third muscle layer within it. You have no control over these. They are completely unconscious, or in this case, they are smooth muscle. That is, you can't do anything about them, the same way you can't stop your intestines from undergoing peristalsis. As you fill up the bladder, there is more and more pressure put on these muscles, and these muscles are trying to contract, and this is what gives you the sense of needing to pee. There are signals from the nerves that innervate this, and nerves that are there to sense what's going on and telling you that they're being activated, which then sends the signal to your brain, and then brain goes, bladder is full, I should pee now. This also generally gets activated somewhere around 300 to 400 milliliters, although the bladder itself, assuming that you're willing to risk filling it to this extent, is about 1 liter or 1000 milliliters. The bladder internally is not any real different to the rest of what we've described so far. There is that inside layer of mucosa which protects it from the damaging effects of urine, and at the bottom itself we have an outlet effectively. This outlet is operated using a sphincter. Now, importantly, unlike other sphincters within your body, you have control over some of these, but not others. The internal sphincter is effectively a thickening and continuation of the detrusor muscle, which is what the bladder muscles are called. You have no control over this as it's an autonomically innervated muscle. Then you have the external sphincter. Now this one you do have some control over, up to a point anyway. If you've ever dealt with extremely young people or the elderly, you'll understand why we say some control. This then leads into the urethra itself. The urethra is where urine will pass through and eventually into the outside world. In males, this is rather obviously going to be longer than in females. This again is much like the rest of what we've described so far in terms of the ureter and bladder. That is, there's a mucous membrane layer, there is a degree of muscle layer, and then this is surrounded by connective tissue. From here, you will urinate out the contents of, your bladder, which will be urine. The urine itself will be made up of a variety of materials, whether this is water, which should be the majority of it, urea, which will be a part of it, hydrogen ions, which will be part of the reason why your urine is acidic. You should also have things like bicarbonate, which is part of the bicarbonate buffer system. You'll have the various electrolytes that weren't reabsorbed. If you have just eaten a rich meal or a diabetic, you may find there's glucose within it. There's other content as well. You may find that there are amino acids, protein, and so on. It is important to note that you may find intermittently that there are, the content within it that you may not want to see. For example, blood, protein, and so on. By itself, these are not necessarily a problem. It very much depends on the context. For example, if you have just eaten a large meal, glucose is not going to be any surprise. If you have recently finished an extremely intense physical activity, you may find that there is protein or blood in your urine, and this is because intense physical activity will increase blood pressure temporarily, and this, as we mentioned at the start of the video, can effectively force content through the glomerulus, and despite it not meaning to. So, unless you have the results on a regular basis, or at least without any more reasonable explanation, you don't need to worry about it. If it is regular, or you don't have a good explanation, then you should probably see someone about a clinical investigation. Now for how the body regulates the renal system. It's largely conducted through hormones, and these hormones are released in response to things like blood pressure, the chemistry of blood, and in some cases, the physical pressure of blood volume and blood pressure itself. The first of these is the RAS system, and that's largely done through angiotensin. Angiotensin is also the target of most blood pressure medications, or at least a popular target of blood pressure medication. First, what we're looking at is the, angiotensin-converting enzyme specifically. That's what blood pressure medication targets. Angiotensin-converting enzyme converts angiotensin 1 into angiotensin 2. Angiotensin 2 is the active form. By preventing angiotensin 2 from being able to be produced, it can't bind to the endothelial cells within the arterioles that supply the glomerulus. And because it can't bind to them, they don't contract. And because they don't contract, you don't have the issue of blood supply to the kidney being decreased. When that happens, you're not removing blood volume. So, by blocking angiotensin converting enzyme, you ensure blood supply is maximized, or at least isn't altered, to the kidneys. Therefore, blood volume is reduced by you taking water out of blood and putting it into urine. Diuretics are a similar problem. For the most part, the human body doesn't necessarily have a diuretic hormone. Rather, most of this is achieved through antidiuretic hormones. These are what largely stop the body from putting fluid, and in most cases water, into urine. Of course, we do consume what are effectively diuretics ourselves, whether this is caffeine in coffee and tea, or ethanol from alcoholic beverages. The body largely deals with the issue of diuresis, or the production of urine, through modulating the amount of diuretic hormone being produced. If you decrease the amount of antidiuretic hormone, you increase the amount of water that is disposed of. If you increase it, you increase the amount of water that is recovered. It also means you're reabsorbing more solutes, like electrolytes. This will maintain blood volume through maintaining fluid levels if it does not increase it. This is done by altering the cell membrane within the collecting ducts, specifically telling it to be more permeable to water and reabsorb more of it. Another way the body ensures that your blood volume and as a result renal function is moderated is through endothelins. These are very small peptides, and what they do is they tell the arterioles supplying blood to the nephron that they need to constrict. By constricting them, there is less blood supplied to the nephron, and therefore less of the fluid, specifically the water, is able to make its way into the glomerulus and through the process into urine eventually. We've already mentioned the next, and that is natriuretic peptides, although specifically we were talking about the atriuretic natriuretic peptides. These are also called natriuretic hormones, although it's up to you as to which you prefer. These have the role of moderating sodium content, and specifically, they pull or push in the opposite direction to aldosterone, where aldosterone is telling the body to decrease the amount of sodium it disposes of. This does the opposite. It says, get rid of as much as you can, and this is done in the collecting ducts. Because it's getting rid of sodium, it also ensures the body is also going to get rid of water, as water will follow sodium via osmosis. And the final example we have that's particularly noteworthy is parathyroid hormone. A parathyroid hormone is, well, rather obviously made in the thyroid, but it's also a relatively short amino acid sequence, about 3 times as long as the atriuretic peptides, but it is relatively small, and this is useful, as it's relatively easy to make and modulate. When it is released, it tells the body to stop the amount of calcium that is in the body. This is done by decreasing the amount that's reabsorbed, and therefore you're going to urinate it away because you're telling the nephron, do not recover this, just let it go. Overall, a urine is made up of a lot of different content, but the most of it is going to be made up of water, followed by things like urea, chloride, sodium, potassium, and so on. The nephrons are essential to making this recipe as it is. If you don't have the nephron, you can't ensure that you recover as much water as you can or need to, nor can you ensure that you're getting rid of what you want to get rid of. Without the nephron, you would not just be peeing away your blood the entire time, but also anything and everything else you need. It would drastically increase the body's demand for things like amino acids, iron for hemoglobin, and so on. There are a lot of things that the nephron recovers that the body desperately wants to hold on to, and for good reason. In order to ensure that the body is able to do this, glomerular filtration rate exists, and this is important. It allows us to carefully modulate how much, how often, and to what extent material is either reabsorbed or disposed of in urine. It's why the glomerular filtration rate is so very high. Consider that the human body has up to 8 liters of blood in it, and that's at the high end. Your kidneys are able to practically clear your body's blood 20 times a day. In doing that, your entire blood volume is cleaned 20 times each day, and you have almost no net loss in things that you desperately need to hold on to. And this ensures your body maintains a homeostatic state. You don't have huge swings in the amount of anything at any given time. Further to that though, the reclaimed fluids and other content ensures your body maintains balance. And that's a key thing here. If the tubules within the kidneys, and specifically the nephron, were not able to accurately, reliably, and consistently clear the blood in the right way, you would find that your body would undergo massive changes from minute to minute, and they would not be pleasant changes. Most of what would be causing those changes is disposed of as urine at the end of the day. This is why the renal system is able to not just remove substances that can otherwise not be disposed of, but it also removes unwanted substances or products such as urea that passively move throughout the body and ensure that they ultimately end up in urine, rather than being constantly reabsorbed and leading to, well, a negative state. It ensures blood volume is what the body needs and wants at any given time, not necessarily what we deserve, but what we need. Further to that, it removes excess ions that would otherwise cause disruption and problems in the body. And finally, there's the matter of pH. While the body can moderate pH via respiration over a relatively short time frame, it's arguably a more disruptive and less reliable and efficient mechanism. The renal system is much slower, but it's able to maintain a much more steady state. All of these features and functions are packed into an organ about the size of your fist. Organs that work every day of your life, from birth through to death, for the most part, and never take a break. Thank you for watching this video. Hopefully you have found it interesting. If so, please consider liking, sharing, and subscribing. If you have found it interesting, consider commenting below.